Our project management team can go to the next slide, please.
And Susan, just a heads up, we are now recording the webinar.
Thank you, Cole. All right, I'm going to turn this over now to my colleagues, Dr. Carol Lannon and Dr. Mike Marcotte.
Good afternoon and good morning, everyone. This is Mike Marcotte. I'm one of the maternal fetal medicine specialists practicing in Cincinnati, Ohio at TriHealth, and the obstetric lead for the Ohio Perinatal Quality Collaborative. We wanted to really set the stage for this webinar and our hopeful plan to have regular webinars as we go through this unprecedented time where we're all shifting our attention to this serious pandemic that is starting to or has rolled into our maternity and neonatal world. And we wanted to set the stage by just mentioning that, you know, we know very little really about this and how it's going to affect us all, and how the implications of it for our mothers and their newborn babies. And we know that every day there is an inundation of so much material and so many pieces of information to try to take in. We wanted to use this hour, and we hope this will be an ongoing series of hours, to come together to set the ground, to recognize the intensity of this experience for all of us, and be together in this, to collaborate. We know that this is a time of high anxiety and a lot of suffering in our world. And we wanted to bring our community together to reflect on that, to share what we're learning in our sites, and to provide feedback and discussion points so that we can all come together on this. We wanted you guys to know that the scenarios and algorithms that we're going to talk about today and in future webinars are from our individual institutions as they try to respond to the pandemic, and they are not OPQC's recommendations as best practices. They really are our opportunity to learn from each other, to reflect, to discuss. Thank you. Next slide.
Hi, this is Carol Lannon. Just to set the stage for today, and Mike, thank you for that. In the spirit of collaboration, our goals for today are, as Mike said, to share the practicalities of implementing strategies now, to discuss what people are doing in situations where it's unclear and formal guidance doesn't necessarily exist, and that it's all teach, all learn. We had planned for this to be an interactive session. We've had 415 people and counting register. Thank you so much. We had many questions come in. Susan categorized them, we reviewed them, and we've prioritized 3 topics to discuss today using scenarios. We're going to have about 15 minutes of a combination of a brief presentation. We'll be looking and following the chat. We will try, if possible, to unmute some people for questions. The logistics are that we'll keep people muted initially. Please use the chat box or the raise hand piece. And just so you know, we are going to record this and it will be uploaded. We will present a PDF of what we're presenting and some additional algorithms. We're dating everything so that you know when it was done, because things are changing quickly. we're going to send a follow-up survey because we think from this response, we will plan to do this for a while yet, probably weekly at this same time. We'll need your feedback to improve. So if this is helpful, let us know that, and we'll plan to meet again next Friday. Next slide, and I think this is back to Mike.
So what we're going to try to do on these weekly webinars is to kind of review what we know as currently as we can. And as you all may be aware, the World Health Organization and the CDC at noon every day gives an update. And this was an update from yesterday. It actually reflects the Wednesday data. And then the Ohio Department of Health gives an update at around 2 o'clock every day for the previous day. So this is also from yesterday. And
Mike, I'm not hearing you.
okay, sorry about that.
There you are.
There's a little technical glitch. So this is what we know at our current data. And as you know, every day we're seeing marked rises. In the United States, I saw data that showed that about every 3 days we're doubling our cases. And in certain parts of the world, cases are doubling even faster, every 2 and almost 1 day in certain countries. In Ohio, we're seeing a similar rise. And we know one of the limitations is how often we're able, or how many tests we have that allow us to actually get the information on the PCR confirmed cases. So we'll be sharing this with you every week so that you can keep track and see what's happening on a week-to-week basis. Next slide. We thought it would be helpful to do some polling, which we'd like to share, and we'll keep track of that on a weekly basis. And we know that there are multiple team members from different hospital systems, so we know it won't be a perfect measure, but we're just trying to get a snapshot of the confirmed cases. And when we talk about confirmed cases, we're talking about those that have a positive PCR test for the COVID-19 infection in their OB patients. So we'll start the poll, and Cole's going to help us with that. And so you'll see something pop up on your screen, and we'll ask you to just answer the poll. We have 3 questions. Okay.
So the first question here, approximately how many confirmed cases of COVID-19 have you had in OB patients? If you have patients and this is applicable, please select one of these 4. Nicole, I'll revert to you. I'm getting something in the chat box that someone is unable to click on an answer.
If you don't see the polls, you can click on the polls button down at the bottom of your screen.
Well, thank you, Andrea.
Okay, when we get to around 50 to 75% response, let's go ahead and end the poll.
Since not everyone's an OB, we may, who's on, we may just want to see where we are.
We're holding at about 39%, so I'm going to go ahead and end the polling.
Thanks.
And share results.
Okay.
Okay. So again, I think one of our reasons for this is that it depends on the spread and also the ability to test in your community. The majority of people have not had a confirmed case at this point in OB patients. Okay, go on to the second question. The second question is
Mike, there's a question about whether we want out-of-state people answering. This poll, I think that's probably okay, but unless we want to keep this as an Ohio-specific poll.
I think for this week, let's go ahead and just have everybody answer, but we may
Shift
that out as weeks go.
Yeah, thanks, Barbara.
So our second question is, how many OB patients do you have or have you had in the ICU with presumed or diagnosed COVID-19?
Only in ICU, yeah. We're trying to look at that. Yes, thanks, Miriam.
Okay, we're holding at about 34% participation, so I'm going to end and share.
Okay, so we are seeing that there are some cases that are going to the ICU. And again, different hospital systems may be putting more patients in the ICU who might get sick, depending on their census. Go on to the third question. And again, this is for our neo-peds colleagues. We're wondering how many babies you've tested for COVID-19 in your population.
Okay, we have 112 responses, 28%, and ending the poll.
So again, reflecting what we're seeing in the OB side, most centers have not seen cases where there's an indication for testing the baby, but some have.
And Patricia is pointing out that if we have multiple people from the same place, we know this isn't accurate research sort of thing. We're just trying to get a sense where we are in what's going on. So thank you. So maybe we want to just move on, I know, to more of the scenarios. Mike, do you want to introduce Nancy?
Yes. Yeah, so wanted to introduce Nancy Kostler. She's the Chief System Quality and Obstetric Lead at the University Hospitals in Cleveland. And if you're from Ohio, you know that Cleveland was the first major center that started to see a rise in cases before we saw that in Columbus and Cincinnati. And so we wanted her to present a case from the University Hospital system of a patient that came to labor and delivery. So we're going to ask her to take just a couple minutes to present the case and to go through the algorithm that they've created to manage those patients on labor and delivery at University Hospital. So thank you, Nancy, for coming on.
Sure, thanks. I'm happy to speak here. Just as a quick background, and you can go to the next slide. I am leading the OB COVID response for the UH system. So that's about 8,000 deliveries, 4,000 at McDonald, which is a level 4 facility, and another 4,000 at 5 system hospitals that offer obstetric services. So this is the pathway for the care of an OB patient, and there's been about 4 PUIs that we've admitted, some of which were diagnosed after delivery, some before delivery. None have turned out to be COVID positive to date. So just stepping back real quickly, we have screening at all of our, and we've locked down our hospital. We have screening at all of our few entrances that are opened. Patients and visitors are screened, temperature is taken, and the screening questions are asked. If an OB patient with no OB complaints screens positive for potential COVID, that patient is directed to the ED. We have never done this before. We have always seen our own patients, and we are in close contact with our ED, but we really wanted to limit the patients coming to labor and delivery to those with obstetric complaints. So the patient and her visitor is screened as she enters the hospital. When the patient presents to labor and delivery with a concern for COVID, and this patient would have been masked at entrance into the hospital, but the visitor and the patient are masked, and then we ascertain whether we have obstetric complaints from this patient or if she appears stable. Again, this is another opportunity. Once we've talked to her, if there is no obstetric complaint, that patient is taken down to the ED for evaluation. Again, something we've never really done in the past, but feel it's important as the surge is approaching. We have 1 room on our labor and delivery. We have 17 labor and delivery rooms, 5 triage beds. Unfortunately, 4 of them are in 1 room. So we have 1 triage room that we have designated as the place where a PUI would go. And you can see right here what we've done. We are minimizing the staff caring for the patient, 1 nurse, 1 senior provider. PPE now includes yellow isolation mask, eye protection gowns, and gloves. The lab has given us the ability, by us I mean labor and delivery, to function as if we are the ED. So we do not call the OB or the COVID hotline about testing. We determine whether the patient should be tested or not. We do the test on labor and delivery. Our nurses have all been trained, and we send the test then to the lab. We have a registry that we're keeping, and then we'll make a decision at this point whether this patient has to be admitted or whether she'll be discharged. Next slide. So this, and I assume you're going to share this slide set after the presentation.
Yes.
This is, okay. So the next 2 pages, I'm not going to go through in detail because I think that you all can read it, but this is essentially a checklist of what we want everybody in the team to be thinking about. You know, we're going to have a huddle once, and you can see that's discuss plan of care on patient arrival and at the start of each shift. What we're going to do in labor. Currently our recommendation, and there's a PPE shortage everywhere, including at University Hospital. So the bedside RN to wear the N95 during prolonged face-to-face exposure, most specifically placement of the epidural. There's guidance for other team members and what they're to wear. There's guidance on what to do with the placenta. Next slide.
We actually, Nancy, we're going to send that out. It was so detailed, we thought we'd, if that's okay. Sorry that you weren't aware of that. We sent a note, but sorry. Sorry about that.
Absolutely okay. So in essence, this is a checklist for you to do through the patient's delivery and her immediate postpartum stay on labor and delivery.
Great. It was,
Thank you so much,
really
Nancy.
great. Yeah, thank you.
Yeah, so we'll, you know, if there are questions specific to Nancy and the UH team, please put them in the chat box. And I think just for a check on time, how are we doing, team?
I think that we're, go ahead, Michelle.
Now go on.
I think that we're filling up the time quite a bit. I think that some of the questions are being answered in there. There are a couple that I wonder if we want to have Dr. Kostler, if she has the ability to answer in the chat box about delayed cord clamping and about negative pressure isolation. But I think that we would like to go ahead and move on to our next presenter, Dr.
Okay.
Bill Schnettler.
And if people
Yeah,
can just,
so,
yeah, Nancy, answer in the chat box, that would be great.
So we wanted to, today what we're going to do is just talk about a case that we have in the Tri-Health system this week of a patient who today just confirmed positive COVID. Just to give an example of somebody who is a critical care patient. But we're not going to spend much time at all on this case today, but we hope to be able to devote more of the webinar in the coming weeks to discuss the critical care patients. But if Bill feels comfortable, Dr. Schnettler, if he could just present the case in a 1 to 2 minute, just to share with the team kind of what we're learning around how patients present and how we're managing them.
Bill, if you hit
Looks like
star
maybe
6, you can unmute. Just hit star 6 and you'll be unmuted.
Can you guys hear me now?
Yes.
Yes.
Yes, thank you.
Great. Sorry about that. So hello, everybody. I'm Bill Schnettler. I'm one of Dr. Marcotte's partners and maternal fetal medicine doctor at Tri-Health Good Samaritan Hospital in Cincinnati. And this has been a busy week for us. We have had a very sick patient come in, one of a few patients that are concerning PUIs. But this patient I'd like to share with you has tested positive just back today, but is currently in our intensive care unit, still mechanically ventilated. She's a 39-year-old gravid 6, para 2031 at 30 weeks and 6 days with underlying history of myotonic dystrophy and bicuspid aortic valve without any aortopathy or valvular stenosis or significant regurg. 4 days, she presented to the hospital on Tuesday, so 4 days prior to that, Thursday, she was seen in our office and really just complained of some rhinorrhea and some watery eyes. So it did have contact with our staff, but then a day later presented to the emergency room with some shortness of breath and cough. A test was performed and actually sent off via a third-party vendor, which still has yet to come back. But she was deemed stable and discharged home. When she presented on Tuesday, she'd had over the prior 4 days worsening cough, and on admission was 93 to 94% on 4 liters nasal cannula. Heart rate was in the 80s, and she appeared very tachypnic, unable to speak in complete sentences, and was maintaining her blood pressures appropriately. The decision was made initially to admit her to our medical surgical unit designated for COVID, and upon perhaps 5 or 10 minutes on that unit, appeared more acutely ill, and the decision was made to transfer her to the ICU. Upon arrival in the ICU, her O2 sat was 78% on 6 liters nasal cannula. We quickly placed a 100% non-rebreather mask, and her pulse ox came up to perhaps 82, 84%. And so within 20 minutes of arrival to the intensive care unit, she was intubated and placed on mechanical ventilation. And her course has waxed and waned over the last couple of days, and we can discuss that and discuss the kind of initial findings that were very suspicious to us on this patient for her to have underlying COVID-19 related viral pneumonia. But she is currently having improvement with various means such as prone position, increased PEEP, various medications that we've introduced, and hopefully, fingers crossed, she'll remain pregnant. Baby is looking great on the monitor right now, And we're hoping and praying that she's going to pull through with this and that we can prolong the gestation.
Thank you so much, Bill. And I know that this will probably generate a lot of questions. We've had a lot of learnings, and we would love to continue to have this discussion and share with other people who have had critically ill pregnant patients with COVID-19.
Dr.
We'll
Schnettler,
move on
we do
to
have
the-
we have one quick
go ahead.
question that I think if you would mind answering. There's a question asking, how do you place the pregnant patient in a prone position?
Yeah, so there's two means of putting a patient in prone, one of which is relatively new, and that's the manual prone position. Historically, we've used a mechanical means called from a company called Rotaprone that does have the abdominal portion of the bed that's removable, which will allow the gravid abdomen to hang down and can enable continuous fetal monitoring. However, the machine takes about 1.5 minutes to rotate from supine to prone, and our concern with that was that that time frame would hinder the ability to perform appropriate CPR in a timely fashion or affect delivery if need be in the setting of cardiopulmonary arrest. So we've manually proned her, which essentially is using a lot of pillows and foam padding that's cut out in the middle so that her abdomen is not compressed, but everything around it, shoulders, upper pelvis, and upper extremities and lower extremities are all padded and supported with the allowance of a cutout for her gravid abdomen to hang down. We've been continuously monitoring the fetus, and even with the straps and belts around her abdomen and tokodynamometry, they've been accurate, and we've been surprisingly pleased with our ability to monitor her despite being in the prone position.
Thank you very much. Very helpful. Like Dr. Kostler, I hope you're able to answer some of the questions that are coming up in the chat box with this, this very intriguing presentation you have here. Thank you very much, and best wishes also for continued improvement with the patient. With that, I'm going to go ahead and have us transition over to the PEDS portion here, neonatal PEDS, and we're going to go ahead and introduce Dr. Heather Kaplan, who is a neonatologist at Good Samaritan Hospital and one of the OPQC Neo faculty. Heather, if you could go ahead and give us the high points of the case study. And I know that you and Dr. Scott Wexelblatt also at Tri-Health and Cincinnati Children's. Thank you.
Hey, Susan, it's Heather. So one of the reasons I wanted to bring up this case, this was a case actually from about a week and a half ago, so very early on in this where maybe the risks weren't quite as high, but I thought it really illustrated kind of 2 points that we can talk about. So for me, particularly on the neo side, this was a case where a mom who had a new onset fever during labor, or in her case, it was in postpartum period, and I got the baby then at 20 hours of life when he became hypothermic. So it was a vaginal delivery of a full-term infant. Mom had ruptured at home, so it was kind of unclear whether she had rupture for anywhere 11 to 18 hours. She was GBS negative, and she had a temperature to 102 degrees Fahrenheit approximately 3 hours after delivery that she said, of course, occurred with all of her pregnancies. So me receiving the baby on the neo side, I'm looking in the chart. I can't find documentation of chorioamnionitis. I'm looking to try and understand where the temperature came from, and was a little bit not reassured for the fact that she had been then not febrile any longer, but she had been on Tylenol and ibuprofen for pain management for her delivery subsequently. And now I'm receiving the baby at 20 hours of life because he became hypothermic and was going to come down to the NICU for a roll-out sepsis evaluation. And I'm trying to figure out, what do I need to be thinking about with this baby related to, is she a PUI, and do I need to handle the baby in that way? So I called the OB just to get a little bit more information. And she said that their team actually wasn't even made aware of the elevated temperature. But she did say that mom had been asymptomatic, and they did feel that the fever was related to the delivery when she went back and tried to investigate. Next slide. So I think there are really 2 points that I think to bring up here to have people think about as you're doing your preparations at your own institution related to how you're thinking about this. So one, I think that's a hot topic is how can you tell the difference between the new onset fever and labor postpartum related to delivery versus early signs of COVID-19. And I think the new article that came out recently from Columbia with their first couple of patients highlights the lack of clarity around this. And whether you rescreen for symptoms in the setting of a new onset fever and labor or in the postpartum period, since many women are coming in asymptomatic. So I think that's food for thought as we continue to have these conversations. And then the other thing I want to talk about a little bit, which I think this case rose, was how important the communication is between OB, Neo, and infection prevention. I think I attend where Bill Schnettler just spoke, and we're doing a great job communicating about that patient, but it's not really just that patient that's the critical patient, it's all of these patients. So in this particular case, how do we make sure that the assessment of the likely etiology of the fever was documented in the chart? In this case, it wasn't. And then how do we make sure that everybody has access to the information on screening of symptoms and exposure in the medical record so that we can all be on the same page related to who's a PUI and who's COVID positive, and can all disciplines and provider types access this and they know where to access it? And how do you really communicate across providers, types, and disciplines related to women's status? I think this case really just highlights that, and I think it can be maybe a piece of the planning that we're doing that we need to pay particular attention to, that maybe we haven't, as we've been so concerned with things related to masking and protecting ourselves with PPE, and how do we handle some of the other things that Scott's going to talk about. So I just wanted to throw these out there as points for consideration in everyone's planning, and maybe for some conversation if there's time.
Heather, thanks for highlighting that. And I think this really allows us to use some of our high reliability tools and to take them, you know, to the next level, including the use of huddles. And at our center, we're actually exploring the idea of developing an OB command center that would be able to bring together all of the critical team members to review the case and make a plan when the patient is real-time there. And this command center would allow us to function 24/7 and actually cover more than just our tertiary center, but possibly our other sites remotely to help guide care and coordination. Okay, well, why don't we move on to the next slide? And again, we know that we're going fast, but we want to make sure we get some really good discussions going, which we can see clearly in the chat box, and we appreciate everybody hanging in there.
Are you able to hear me okay?
Yes.
Great.
Yes, thanks, Scott.
So I just wanted to go over some of the information that we've come up in our region in Cincinnati. And as was mentioned earlier, all this information is expert opinion. There's no studies. This is a new disease. We don't have really any standardized practice yet. So what everybody goes to their certain channel for the weatherman, and they're basing it all on expert opinion. So what I'm going to tell you may be different than already has been being done up in the Cleveland area. And like I said, we're still trying to learn this all together. So this is CDC is recommending maternal and infant separation immediately following delivery. We want to make sure that you have the recommended number of attendees in delivery that NRP is recommending. We do want to decrease the amount in there, but we still want to have a safe number. Infant needs to be in a separate private room, recommended be in a separate private room under droplet precautions. But you can see here in our region, we decided to do cord clamping, not to do cord clamping if the infant was above 32 weeks, but below 32 weeks, we were still discussing the benefits of cord clamping for those premature infants. We are changing our bathing protocol. Instead of waiting to 12 hours, we are bathing the baby as soon as he or she is stable, and then administering the newborn medications. And then if the mother is positive, we want her to designate a healthy care provider. If she's positive, this obviously has to be a non-household member, as everybody in the household is going to be considered positive. So the next slide is what the California group has come up with. And so it's more of a shared decision model. So we have our recommendations of separation, but if the family is adamant and doesn't want to do it, then we need to make sure that the infant, or it's a PUI, not a positive, and we're not sure about how positive it is, we're recommending is 6 feet of separation from the mother, everybody having some airborne and eye protection in that case. For feeding, the recommendation is to use express milk, not to do direct breastfeeding. However, with shared decision, if it's a PUA, not a positive, then having mom breastfeed, making sure that she is, and we have a full slide coming up on that full verbiage. And then you can see there's visitation of, father refuses in the PUI version to separate, then that is also a decision-making tool. So lots of different variation, and what we talk about today is probably going to be different than what we talk about next week. On the next slide is going to be a poll regarding breastfeeding. So for mothers that are PUI and planning to provide breast milk or breastfeed their infants, what is your hospital planning to do? Are they allowing direct breastfeeding with mask and appropriate hygiene? Are they providing only express breast milk with appropriate hygiene? Allowing either direct breastfeeding with mask or express breast milk per maternal wishes, or we haven't even come to that decision yet. So we'll open up that poll right now.
Dr. Wexelbat, this is Susan. While people are filling out this poll, there is a question that someone would like some further clarification as the reason for not doing delayed cord clamping.
Yeah, and so this is for our premature babies with the risk benefit for them with the protection of delayed cord clamping for intraventricular hemorrhage and improved outcomes. And so that is why we picked that number of 32 weeks as our value based on the benefit below 32 weeks for doing delayed cord clamping. And that's the information that ended up leading to expanding our delayed cord clamping to our term babies, was all that information done on the premature infants.
Thank you. I didn't want to hijack our poll. How are we going there, Cole, with the percentage of responses?
We are at about 28%, so I'm going to give it a few more seconds and then close it.
And the reason that we say to consider not doing cord clamping is we are not 100% sure if this is a vertical transmission or if it is horizontal. So since there is some identification possibly of COVID in amniotic fluid, so at this time we don't know what the risk is. So it's always do no harm, anything we make a decision in medicine, and we just don't know the risk benefits at this point. So you can see we're pretty split here on our poll questions, with majority are saying are allowing either direct breastfeeding with mask or express breast milk per maternal wishes, and not sure yet. I hope next week when we actually redo the same question that we have that 28% down to 0 or 1%, because I think everybody's going to be experiencing this question in real life, hopefully over the next week, unfortunately. So the next slide or poll is for mothers that are COVID positive and plan to provide breast milk or breastfeed. Our hospital is allowing direct breastfeeding with mask and hygiene, provide only express breast milk with appropriate hygiene practices, allow in either direct breastfeed or express breast milk, or we're not sure yet.
And so this differs as mom is identified as positive as opposed to just PUI. And we'll take a minute here.
To clarify that.
No, that's okay.
The poll didn't pop up for me, Susan. I don't know if it did for others.
Cole, are we able to pull it up? There we go. Thank you, Heather. So again, this is for the COVID positive mom, which differs from the last. It was just a person under investigation.
And I know there's a comment about the WHO recommendations. Those are going to be different than local and CDC, and that's based on areas that don't have access to formula or other means or nutrition. So I think WHO recommendations are always going to be a little bit different than local recommendations often. Well, that's a great point to fill out.
Okay, I'm closing the poll at 28% and sharing the results.
Thank you, Michelle.
So the numbers you can see are a little bit different here when we have actual COVID positive mom versus one that was a PUI. And we are getting a little bit more push to the encouraged pumped breast milk, but are allowing breastfeeding with mask and appropriate hygiene. So our region are hoping that for COVID positive, we are doing the separation if mom allows it. So obviously, if we are doing separation, the only way to feed would be express breast milk. But if you are not doing the separation, then that would be a way to do that. And hopefully, like I said, that 24% of not sure yet gets together. And then the next slide is a breastfeeding link by the CDC. And what this says today is going to be different than next week. So I think this is just showing that there is a link. And Susan, I don't know if there is anything more besides the link or looking at this slide as it's going to be changing daily.
Scott, I agree with you. I think that it's important to be up to date and note that, yes, the CDC is recommending breastfeeding, and these are the precautions to take.
So if she is going to be breastfeeding, we want to make sure they're washing their hands thoroughly, wearing a mask, and then wash your hands before touching any pump or bottle pots and clean all afterwards. Next. And so this is our statement that we came up with our region to go ahead and sort of combine and shared decision making, and that we are encouraging all mothers to provide breast milk for the infant. It's just deciding how we're going to provide it, either with direct breastfeeding if they're a PUI, or during temporary separation, making sure that they're encouraged to express breast milk to maintain their supply, and that when possible having that they're deciding that if we do room in, that they're doing as much PPE as possible. And this is just what we're recommending in our region. And then the next slide is just really talking about what to do at discharge. It's a little bit different. So we are, as was mentioned earlier, we are not recommending our full team being called to a delivery if we wouldn't otherwise. So just because a mom is COVID positive, we don't think the peds resuscitation team needs to be there, but just aware. But at discharge, we are recommending not an early 24-hour discharge. I know the pushes say we need to get this mom out of our hospital to prevent spreading or affecting our patient, our nurses, and everybody that's coming into the room. But we really don't know about vertical versus horizontal. So we are recommending not doing a 48-hour discharge, making sure that everything is stable. And that really the key point here is we're encouraging everybody to do direct physician to physician contact prior to discharge. Some groups we have found are not taking new patients if they are, because they are not doing sick visits. And this is, even though this is a well child check, they are considering a mom that is COVID positive to be a sick visit. So we really want to make sure that we have direct handoff, making sure that they can either make this the last patient of the day so they can clean the room thoroughly afterwards, or making sure how we're going to get the testing followed up if we're doing testing. And then also encouraging telehealth if necessary for discharge instructions if the mom is separated. And some families have really we've been able to do that in our region already. But really doing the direct handoff is a key important factor, just sort of like what Heather was talking about in the hospital, the direct contact with our OBs and infection control colleagues is calling these primary care doctors to let them know what is going to be coming to their office in 2 to 3 days. I think that was the
Thanks
last
so
slide.
much, Scott. Yes, thank you very much. That was really helpful. I did see that you say telehealth, and there's something in the chat box as well about utilizing FaceTime for patients that are not allowed to have visitors. So again, our chat box is very full and full of wonderful feedback and questions. And Dr. Buxelblatt, I'll ask you to also hopefully answer or respond to some of these questions in the chat box as we move on. On our next slide, we're going to go ahead and transition to workforce considerations. A vast majority of questions that came in on our registration were from individuals asking about workforce considerations. Jennifer Doyle is the advanced practice nurse at Summa Health over Women's Services, the Women's Services line, and she's going to share with us what they're doing at Summa Health in response to this. Jen, I'll let you go ahead.
Sure, thanks. And certainly this requires multi-disciplines, having multiple meetings, talking, and I shared many of our templates with OPQC to share with you all. But, you know, I will tell you that it is ever changing, as Dr. Marcotte noted before. But here's a couple of things that we've learned or are implementing right now. Having a provider pool of specifically physicians. Even private groups can get together and designate somebody to be the OB hospital service. I mean, yes, we have hospitalists, but this is another option. And if you have a positive COVID patient or a PUI patient, really, again, as other people have said, limiting the number of people coming in and out of the room. So really designating a single provider, which would most likely be the attending physician, or certainly a high-level provider. What we don't want to have is an intern or a second-year resident who then, if there's an emergency, can't do a C-section, then you're getting more people involved. So really from the beginning, designating probably the attending physician to be with that patient, as well as nurse staffing considerations being one-to-one. Of course, using the PPE, leaving their phone out of the room. Don't take your phone in, remove jewelry. Learning on the A1 Ohio, on an A1 Ohio resource call yesterday, using a clear lab bag over the badge, because as nurses we need to be badging and punching in for, you know, everything from orders to meds to lab work and so forth like that. So we've developed a staff tracker sheet that was suggested by a call with the CMQCC call, so that we're logging if you have a positive COVID patient or PUI patient, logging who is going in and out of that room, and what gear are they wearing, and why are they going in and out. So that way there's a way to track staff later as needed. We've developed an ED algorithm, outpatient prenatal care and assessment algorithms, letters for our patients, you know, explaining to them that right now we're allowing one visitor with a mom, positive or not. If there's no and they're not PUI, they're not positive, the visitor can leave one time in a 24-hour period, but of course they would have to be rescreened upon re-entry. Only one visitor, has to be the same visitor, same for our antenatal patients. One visitor, the same visitor, is the only one that can come for certain hours of the day. Certainly if we have a PUI or a positive COVID patient, the one visitor must have PPE as well. Is there a next slide? So that's what we're doing, but again, everybody kind of is going to follow your own policies and procedures. Next slide.
Thank you. Thanks so much, Jen. That is very helpful. Some very practical advice there, specific to staff. We'll transition now to.
And you know what? I'm sorry. Can I just?
No, go ahead.
I had a lot more. Apparently, this slide was changed, but just a couple other things that I don't see here, but are going to come up. Nitrous oxide for analgesia in labor is probably a no-go, especially for PUI and positive COVID patients because of the aerosolization. And also oxygen use for intrauterine resuscitation is sometimes positive. CMQCC says yes. Some places are saying no. our infection control, we're looking at whether it's a high velocity oxygen, 10 liters by non-rebreather face mask, and whether we have to wear extra precautions, whether that's an aerosolized event or not. So, but certainly if you have a patient with oxygen mask, our infection control people are still saying that you would still put a mask over the oxygen mask. So just a couple other labor and delivery tips.
Sure, Jen, you
Thank
may
you,
want
Jen.
to put
And
those in the chat box.
absolutely. And we will be posting this to our OPQC website as well. We'll transition to the next slide and have Dr. Patrick Snyder from the Ohio State University Wexner Medical Center. Dr. Snyder, I apologize. We are getting towards the end of our webinar. So in the next few minutes, if you could go ahead and speak about the workforce adjustments at your institution and some suggestions that you found helpful, that would be wonderful.
Absolutely. The case I'm showing here is actually a case that hit me personally on Tuesday. So essentially I was texted by my partner that they were having chest pain, shortness of breath, a dry cough, muscle aches, and then also fatigue. From there, I encouraged them to go get the appropriate testing, namely so that their needs were addressed and any anxiety that they might have as related to that testing was appropriately addressed. But then also allows me to potentially take steps from our institution that's recommended, which are to, number one, obtain PPE so that it can be used in a home setting, actually, to kind of, when you do have those interactions with your family member or partner, that you're not potentially exposing yourself, maintaining an appropriate distance when possible to do so. That includes sleeping in separate rooms if possible, or separate spaces. But then also, again, trying to be mindful that you're trying not to pass this along to yourself. Towards that end, I think the next steps in that process are really talking to leadership, and that includes internal hotlines if they are available for triaging. In our case, Ohio Department of Health is one of those hotlines, in addition to departmental leadership to determine the need for testing, as well as coming off of coverage and potentially having people come into the space that you were at. Fortunately, by the time that I learned of the symptoms and things of that, we were already down to our last patient of the day. So I chose to see that last patient with PPE on, but obviously it depends on kind of the timing of the day when that is, and potentially allowing for shifts of coverage as was offered by my leadership at that time. It also allows for the potential to tap into resources that you might not never always recognize or easily available, such as mental health services or other things that can potentially be helpful in terms of internal things within your department, so that people are providing you with resources in case you're having to run low on groceries or other kind of supportive things to make sure that you are well and continuing to stay well. And then lastly, just kind of talking about the healthcare system and the hospital system in and of itself. I think really importantly, we've taken a lot of efforts to develop preparations so that we had this flexibility to accommodate me coming off of the work team, namely because we just didn't feel that it was safe with a potential unknown exposure and me being in close contact and proximity to that person, that we felt like this was something that should have been addressed. And we had started to address it, but we are taking further steps to develop work care teams, even in the outpatient setting, such that there's a dedicated group of providers that mostly dedicate their services to the outpatient team, with appropriate contingency plans for if patients, or so if providers do get ill or other healthcare workers get ill, that we can move down the chain of the process to allow for shifts in while people are getting their testing and results back and seeing whether or not symptoms develop in that time. I think one of the important things to consider in that is that it is very system specific for that. So it is something you have to kind of talk about with not only the providers, but also the medical assistants, the nurses in the group, as well as thinking about travel situations where you're going to offsites, such as remote locations for consultations or other clinical care that's provided. An example is that we go to Chillicothe down south from us at Adena Healthcare, and while they've not really had any cases at all in their particular county, they're still taking the appropriate precautions, and we're trying to do everything we can to schedule patients who don't necessarily need to have that ultrasound right then that day, and trying to shift more towards seeing patients that really do need to be seen, delaying imaging where possible, spacing out imaging visits, as well as trying to employ televisits wherever and whenever possible. Ideally, those do involve video chats when possible, but at the same time, in a pinch, I think phone chats are equally as helpful, because really it is a more matter of the communication, understanding what that patient needs, in more of a communicative role rather than sometimes the physical examination sometimes that we are required to for billing purposes, but that we can usually overcome by appropriately asking the right questions.
Thank you, Dr. Schneider. That is spot on. I would agree with you, as I am at University Hospitals of Cleveland, like Dr. Kostler and Dr. Walsh, and we too have an internal hotline that is being utilized amongst staff, and I appreciate you bringing that up to make certain people as a reminder to utilize, as is the telehealth that you bring up as well. I'll ask also if you're able to go into the chat box as we're wrapping up with the last couple of minutes here and answer any of the questions that are there. Let's go to the next slide. And I think everybody on this call realizes that there is really quite a bit more information, topics, items that we could cover that we just could not in this one hour. Future discussions that we are hoping to move forward with these calls, perhaps on a weekly basis, with this trajectory changing so frequently. Modifications to in-person prenatal care and telehealth, I think, is really something that we would like to tackle, as well as the substance use disorder, pregnant women with opioid use disorder, and how this COVID outbreak pandemic is affecting them. Breastfeeding recommendations, lots of talk in the chat box about that. I know we could go further into that. Visitation and PPE recommendations as well seem to be very hot topics that perhaps would be something that we would want to cover on future webinars. If we go to the next slide, I do want to let everybody know we will be posting this on our website. That is opqc.net. Please also feel free to email us at info@opqc.net. We can answer your emails there as well. We will be posting this slide deck, as well as many of the other items that our presenters discussed and shared, and we will be looking forward to hearing from you as well. Carol, Mike, Dr. O'Flynn, and Dr. Marcotte, any closing words?
This is Mike, and I can't tell you how much I appreciate having this hour time for us to come together and think and talk about this really most difficult situation that we're all faced with right now in the world with this new virus pandemic. And I just would encourage everyone to start their day and end their day with coming together with their team, either virtually or together in person if they're working at the hospital, to just take a minute to just reflect on their day and how important it is to work together. So I really think that this is an important time for us to continue to collaborate and figure out how we can get through this with hopefully the least amount of suffering for our population and for ourselves, and to continue to remember our dedication to that. So thank you all, and we'll look forward to talking again soon.
And next slide, I just want to say thank you so much. We hope this has been useful. You'll be receiving a follow-up, and take care, everybody, and thank you so much for all you're doing every day.
Thank you, everyone. Special thanks to our presenters throughout the state, for our project management team, for pulling this together, and especially for all of you caring for the patients and pulling together to learn what we can from each other. Most appreciated. Have a safe day, everyone. Bye-bye.
Bye.